Welcome to Realizing Resilience, a podcast from the Connecticut Women's Consortium. We're not behavioral health professionals, but we're your gateway to real conversations with the experts. Each episode, we'll delve into the vast landscape of mental health, from personal stories to expert insights. Together, we'll bridge the gap between clinical expertise and personal experiences, connecting with diverse voices and perspectives. Join us for insightful conversations that demystify the world of mental health.
Dr. Lauren Doninger has been in the field of mental health and addiction services since 1983. She earned her bachelor's in psychology from Nassau College, her master's in community psychology from Central Connecticut State University, and her doctorate in higher education leadership from Johnson & Wales University. Dr. Doninger is a licensed alcohol and drug counselor and a licensed professional counselor. She has worked in a variety of clinical settings, including residential, detox, outpatient, intensive outpatient, and with many different client populations. Currently, Dr. Doninger is a professor of psychology and drug and alcohol recovery counseling at Gateway Community College in New Haven, Connecticut.
All right, welcome back to Realizing Resilience. I'm Alana. Unfortunately, Marissa cannot be with us today, but nonetheless, I am so excited to be speaking with Dr. Lauren Doninger. Thank you for joining us today.
Thanks for having me.
So first and foremost, your work focuses, the work that you're doing with us focuses a lot on biology of addiction. The two courses that you will be training on are entitled Biology of Addiction. Why is it important to think about addiction like a brain disorder rather than a social issue?
Well, primarily because it is a brain disorder. Often when I start my trainings, I tell this story. When I started in the field in Connecticut, we had the Department of Mental Health and the Department of Addiction Services, and nobody spoke to each other. And people in addiction services didn't want to deal with people with severe and persistent mental illness because, they're crazy, they're scary. And people in mental health field didn't want to deal with people in addiction services because, they're drug addicts. This is an auditory medium, so I know people can't see me doing the air quotes for the non-person-centered language, but I would not use that language now. I'm giving you the language of the time. And I had just the dumb luck of having a brilliant clinical supervisor who was way ahead of her time, Linda Filippetti was New Britain General at the time. And Linda just understood before I think most people did that these are the same people, that we need to treat people holistically. We can't shuffle people off because they have a co-occurring issue. And she asked me if I was interested and would I go get training. And I was young and I was eager, and I did. And I started doing some work I did some work in the detox unit, in the IOP and outpatient, a whole bunch of different treatment settings. And I would sit with clients who would say, I am never using again. Oh my God, my life is in ruins. I'm never using again. DCF is going to take my kids. I'm going to get violated on my probation. And, I would believe them and they would believe themselves because they absolutely meant it. And then they would relapse. And it's illogical, right? It doesn't make evolutionary sense to continue to use substances. If punishment could resolve addictions, then they would be self-correcting, right? Because the punishments are relentless. They start out small, they get bigger and bigger, and people are in a state of profound suffering and misery, and yet will continue to use the substances. And that was really the thing, the just lack of evolutionary purpose that made me want to sort of really understand what was going on in the brain. And the way I approach the material and the way I understand it is from a counselor's perspective, right? I'm not a biologist, I'm not a physician, I'm not a nurse, I am a counselor. And I wanted to understand this content so that I could explain to the client why, even though they were trying so hard and doing the things that so many people in their lives were doing and still just felt so terrible and had such profound craving. Why was that? And more importantly, can that get better? And the answer is yes, because addiction isn't a moral failing or a character defect. It's a brain disorder. It's a brain injury. And with any other sort of severe injury, there's this clear recognition that we need time, we need rest, we need good nutrition. And those things are often not afforded people who have the disorder of brain structure and function that is addiction, because it's viewed as not just a social ill. I mean, I think you're right in your question, which Why is it important to make a distinction that it's not just a social issue? It does have social manifestations, but at its heart, it's a brain disorder.
Compassion, too, is part of that distinction, where I feel like because mental illness is viewed as scientifically provable and it's a thing that has had more like academic background associated with it, people respect it more as being closer to a disease. I feel like there's still a long way to go there.
Yeah,
but,
there is.
But substance abuse is even further removed, where people do see it as a choice, which, like you said, is insane because you're being punished constantly for your addiction.
I think a lot of that is because typically the initial use is voluntary. So often people will view it as like self-inflicted. And it's true that the first use is typically, not always, but typically voluntary, but it is behavior elected most usually by a child. Now, addiction is absolutely a pediatric condition. Often the full manifestation and the full consequences aren't fully revealed until somebody is an adult, but it's launched in adolescence. 14 is a magically dangerous age. Kids who use at or before the age of 14 are enormously at greater risk. So it is initially typically a choice of a behavior, but it is a choice that a teenager makes and then continues to pay for. And, I don't think there's any teenager who would want to continue to have the consequences of those teenage poor judgment. But that is what happens with a substance use disorder. So I think that's one of the reasons, is this notion that it's a choice.
This is just a thing I'm kind of curious about because they are so heavily linked. Most people, it's co-occurring. How does the impact of treatment with substances like ketamine, I'm thinking about especially as being a depression treatment of recent, and marijuana being talked about as an anxiety treatment, how does that impact research or treatment?
That is such a complicated question. So there has been this interesting research around ketamine as a treatment that for some people is life-changing for depression. Ketamine is a drug of abuse. It is one that has significant potential for damage, and it needs to, and I think at this point is pretty tightly controlled. For somebody to access ketamine treatment for depression, well, there are lots of access issues, including the fact that a person has to be able to go into an office. It's not a take-home medication. They have to go for multiple visits. They have to have a ride both ways. There are obvious equity issues there. You have to have the privilege to be able to go to multiple daytime appointments, to have coverage, to have somebody who can drive you. So that formula, of course, anything can get diverted, but the ability to divert with that ketamine that's used for depression is pretty different than diversion that we see for other medications, like certainly opioids or benzodiazepines, or treatments for attention deficit hyperactivity, like Ritalin and Concerta. The research, some of the research that will be really interesting is around substances similar to ketamine, in that there are other, what might be classified as psychedelics or hallucinogens, things like psilocybin or acid, LSD. And there is really interesting research that's happening now. Those substances have much lower addictive liability than most any of the other substances that we would talk about in a biology of addiction training, or that we see sort of causing the social harms in addition to the biological, psychological harms. So it's going to be a really interesting thing to watch unfold. Marijuana, on the other hand, when I would teach about marijuana in my, I teach at Gateway Community College, and in the biology of addiction 3-credit 15-week course, I get to the unit on marijuana and I'd be like, my least favorite substance to talk about, because so many of the arguments around marijuana lack any sort of critical thinking or evaluation, right? Like there's this notion that marijuana, air quotes, it's just weed, it's only natural, cyanide is only natural, lye is only natural, but we don't think that we should just ingest that. And there's this notion that it's medicine, or, nobody ever died from marijuana. And those things might be true. We haven't been able to adequately research the medical utility of marijuana because it has been a Schedule I, it still is a Schedule I substance, meaning that according to the federal government, it has no medical usefulness, it has harm potential, it has addictive liability. Because of that scheduling, which is part of the Controlled Substances Act from the 1970s, like everything from the 1970s needs to be redesigned, including that, it hasn't been possible to do really meaningful research. It is entirely possible that in 2024, marijuana will be moved to Schedule 3. That recommendation was made in September. That will be a monumental shift because that will lead to meaningful research. So right now, when we talk about its medicine, there isn't any other sort of pharmaceutical where the method of ingestion is combustion, right? Or where you might be prescribed marijuana for, somebody's going through chemotherapy and they have nausea, or maybe, they have too much dandruff, right? Like anything can get a prescription for marijuana. And anecdotally, people certainly feel very, very helped by marijuana. And personally, like from my personal perspective and value system, I don't have any problem with it. Like, I think this may be down a different rabbit hole. I don't think anything should be illegal. Like, it has not worked well for substances to be illegal. But in terms of, is it medicine? There has to be real research to know that. There have to be controlled trials. And that hasn't happened. Even when we say marijuana, well, what are we talking about? Like, there's so many different chemicals. Typically, the chemical that people are seeking to get high is THC. The other really prominent chemical is cannabidiol, CBD. There is evidence that the chemical that likely has the greatest medical utility is actually the CBD, which has been largely bred out of a lot of marijuana because it doesn't make you high. Meanwhile, CBD technically is still a Schedule 1 substance, but you can get CBD added to your coffee at some coffee shops. And it's not controlled. Like, there might not be any CBD, or it might be so little as to make no difference. So really it's a placebo effect. If a placebo effect is helpful, like, great, placebo effect, whatever works. But the other thing that happens with all of this conversation about marijuana is that there's a suggestion that it is somehow a benign substance, and it absolutely is not. Marijuana absolutely has addictive liability. It is a much lower addictive liability than many other substances, lower than nicotine, certainly lower than opioids, but it's not zero. And people who are brought to their knees by marijuana are brought to their knees in the same way that any of these other substances can derail a person's life and have really specific consequences to the architecture of the brain, especially when an adolescent is being exposed to high THC marijuana. So there's a long way around to answer your question, but the way that it would affect research would be for there to be actual research, which if it's moved to Schedule 3, we can really find out the utility of marijuana.
It's complex because it's federally illegal, but in certain states it's legal. Like, it just became legalized in Connecticut recently for recreational use. It's just so crazy to think about the fact that you can buy it and not get in trouble, but then on a federal level, on like a weird technicality, you could.
It's a states' rights issue, right?
Yeah.
Like, so the feds have sort of said, we won't look, but they could. Any of the legal dispensaries or stores in Connecticut, that they have all sorts of issues around banking because banks go through the federal government. To me, it's an interesting study. Like, the way that we got to recreational marijuana was really a very brilliant long game via medical marijuana, right? Like, so lobbying groups that wanted legal recreational marijuana, the path that they took over the course of like 25 years was to talk about medical marijuana. Even though, in terms of how we understand medicine, there's a known dose, it has a known effect, it has a known side effect, it's not taken by combustion. Marijuana is none of those things. But those were the cogent argument, right? Like, if somebody's in chemotherapy and marijuana helps with the nausea, who should deny a person that? Why should a person have to buy a potentially dirty, contaminated street product to get that relief? But it's medicine. That's one of those sort of overly simplistic arguments that's coming around, and the research will change. And, there's one, it's called Epidiolex. I hope I'm pronouncing that right. Epidiolex, I think so. It is a seizure medication, and it's CBD, and it's one of the first, here's the actual medication. There's also a medication called Marinol, which is like, it's a pill, it's like a synthetic marijuana, synthetic THC, taken in pill form, often used for people who have appetite issues, either because they're sick or they're on chemo, and also for muscle spasms for people with like multiple sclerosis. So there have been actual pharmaceuticals that mimic THC, but a whole bunch of options are going to be available when and if that changes. I think it will.
That's exciting that there will be actual research.
Yeah.
So going back a little bit to what your trainings will be like, what kind of things occur in your training. So the first one you have with us is on January 9th. That's
Yeah.
the biology of addiction, the first one. You mentioned that it will discuss current trends in substance use and regulation. So we kind of got there a little bit, but what do you feel is important there to have your audience take away?
The first half of that training, like the morning half, is really here's the basic biology. Here is how we understand how neurotransmission works, how the central nervous system works, how drugs of abuse interfere with the basic homeostasis or internal stability, and how substances that have addictive liability can lead to things like tolerance and withdrawal because of changes in internal stability. So it's biology from a counselor's perspective, like the neurons and the neurotransmitters that I draw are the type of thing that you might draw for a client. They're nothing that neuroscientist or or physician, very simplistic, because my intention is for people who, come away from the training to be able to draw this basic neuron and talk to a client about here's what's happened with your internal stability, with your homeostasis. This is a brain injury and it can heal, but it will take time. If you broke your arm, you would not be surprised if you couldn't play tennis like 3 weeks later if you felt fine. So drawing like here's what happened, the brain has plasticity, the brain can heal. So to make it very concrete, and one of the things that in these sort of very simplistic drawings and understanding of neurotransmission is to look at this structure deep in the brain called the amygdala. It's this little almond-shaped structure that's responsible for emotional memory. So this almond-shaped structure that is responsible for emotional memory and for reading emotional cues. It goes to sleep. One of the structures that goes to sleep in the presence of alcohol, which is why men in particular will end up in a bar fight because the amygdala is asleep. So one of the things that happens when their brain has been altered by exposure to substances and the amygdala remembers the euphoria, remembers the relief of the substance. When a person, they can be briefly just newly in recovery, or they can be long in recovery, and they see something or smell something that triggers the amygdala. There is a chemical cascade that happens from that emotional memory triggered in the amygdala that will send a person into a profound state of craving. And it's not because they are suddenly weak-willed. It is this physiological thing that's happening. There is a cascade of neurotransmitters. And that might be interpreted by somebody, it's certainly often socially or publicly as being weak-willed. But everything psychological is biological. And that is happening because something biological is occurring. So the first part of the training, I want to help people who attend get this sort of basic understanding so that they can help clients understand why the suffering, why isn't it, if all it took was insight, if all that somebody needed was to want to stop, then self-correcting, people would stop. They can't because there's this brain injury that can repair itself. Then we move in to talk specifically about alcohol and then opioids and then maybe stimulants. And I say maybe because I like to really pursue whatever questions that people have, and that might then mean that the stimulant ends up in the continued conversation. Then the continued conversation, the substances that we talk about are often really driven by what attendees are looking for. Typically marijuana. People are often very interested in marijuana. I try to fit in nicotine. If we haven't talked about stimulants in one, we'll definitely talk about it in two. And then some of what are called the NPS, the novel psychoactive substances, things that are like slapped together in a filthy, dirty bathtub and God knows what's in them, like bath salts and synthetic marijuana, things that have multiple actions like ketamine or PCP, phencyclidine. But it's funny, I just was working on my PowerPoint actually just this weekend, and the nice, neat categories that I used to have for my training, those are gone because we're in what would now be called like a fourth wave of the opioid crisis. And this fourth wave really has to do with opioids like fentanyl being found in everything, found in marijuana, illicit marijuana, found in cocaine and other stimulants. So It's not accurate to talk just about opioids as if the opioids aren't found in so many other substances now. I was deciding about where to talk about xylazine, which is not an opioid, but it is a central nervous system depressant. Street name is typically tranq, and it's often taken with opioids. There are certain sentinel areas. Philadelphia is a sentinel area. 10 years ago, it was Puerto Rico. So it's hard to say, like, here's exactly what we're going to cover. Polysubstance use, adulteration, contamination will follow the path that the attendees are interested in and the things that they're seeing. Alcohol and opioids for sure.
I know you've been doing this with us for quite a while. I think it's great that you're evolving as, I don't want to say trends.
Yeah, no, it
but
is.
as drugs change and evolve and their impacts on people change and evolve, that is so beneficial to attendees. People are probably going to be really excited to attend this training. I'm hopeful.
I hope so. I try to, it's such a serious topic. It's so, people are so devastated. Families are devastated. Communities are devastated. So within the framework of understanding that this is devastating, I do try to provide an engaging training. I, try to do a lot of being the attendees sort of answer questions or take a guess, and to try to keep people involved, because it's pretty heavy. And often people are worried, like, they're going to be back in, sophomore year biology. No, this is going to be like accessible from a counselor perspective, what we need to understand. So yeah, hopefully people find it useful and interesting, and maybe most importantly, applicable to their work. I tell students, not, professionals who are coming to a training, but I teach abnormal psychology at the undergraduate level. And when I talk about the different diagnoses, let students know that there are all sorts of sort of interesting and exotic diagnoses that people are interested in, factitious disorder, dissociative identity disorder. And like, maybe there's a chance they will see that in the course of their career. But if they are a human being, like living in Connecticut, living in the United States, living anywhere, they are going to see substance use disorders. If they are only taking a class because it fit in their schedule and they needed 3 credits, they are still going to see substance use disorders. There are people in their life who are struggling, who are suffering, either because they have a substance use disorder or somebody they love and care about has a substance use disorder. So having some awareness, and as you mentioned, like compassion, because nobody wants this, like nobody's choosing this for their life or their loved one. So I think that awareness that is not whatever popular media and popular culture talk about, which is often so oversimplified as to make it sound like somebody, if they really wanted to, they would just stop. Well, they do really want.
Yeah, I'm intrigued, and it's not relevant to my course of work. So I think, like you said, it's a thing. I was just talking to one of my friends about this, that someone, or someone who knows someone pretty much at this point, especially in Connecticut, is in a really dire place.
Yep.
So I think this is relevant for anyone.
In the nation, opioid overdose, we are number 13 out of 52. It's bad. 50 states. I have a funny story about that, but I won't, about 50 versus 52 states. When I updated this slide, like data usually comes out every 2 years ago, we were 10th. So 13th is better, but it's still bad.
Yeah.
Yeah.
The way that you were talking about it, I assume that most people attend both trainings. And typically, I imagine there are things that you still want to know after the first. If you are a person who can only attend the second, how can you kind of get caught up, or how do you sort of help new students acclimate to an environment that might already be formed?
If somebody can only attend one, I think the first one is more important. If they can only attend the second, then, I'll catch them up. I'll sort of get a feel for who's in the room and give. I obviously don't want to spend a lot of time on repeat, but try to be sure that people are caught up with the basic biology.
Yeah, I think as we come back in person, especially with series-based trainings, people might be a little bit worried that they have missed something if they can attend all of them. But even from just talking to you, I feel like it's extremely accessible, the way that you present this content. And I don't even have a slideshow. So
Thank you.
You're welcome.
I hope that people come in person. I know that there's a lot of, like, if you do remote, then more people, but I really think you lose something when you're not in the room together. And I know that I'm guilty of, okay, I'm logged in and I'm on this screen, like doing the other things that are pressing on me. There's something about being in the room where you're more present. So I hope that people are willing to, come and do it in person. I guess we'll find out. I'm a puppy raiser for Guiding Eyes for the Blind. So I usually always have a dog with me. So, whatever motivates people. The current puppy is Bijou. She's a black lab, and she will be at the training unless she gets called back. If I have a new puppy wouldn't be with me. The one I have now is a little, she's 18 months. So she'll be silent in the room. And then at break, people can get their oxytocin rush from puppy love during the break.
That's great. That's
my motivation. Come for the puppy.
That's kind of like the perfect collaboration of careers where you're kind of doing something where you inherently can expose the dog to scenarios it'll need to be in. So
exactly right. Exactly.
That's great.
Right.
All right. Well, thank you so much for talking with me today. I feel like I could ask you a million more questions about this just because it's so interesting. Links will be in the description to keep up with us at the Connecticut Women's Consortium and to sign up for Dr. Doninger's upcoming trainings, The Biology of Addiction on January 9th and The Biology of Addiction Continued Conversations on March 11th. Thank you for joining us today. See you next time, and be kind to yourself.